afternoon, everybody. Thank you for joining us on this miserable Monday afternoon. These online learning events that we've run last Monday and today are specifically in relation to the update to the 2022 National Consent Policy. And this week, we're going to be looking at 3 new templates in Appendices 6, 7 and 8. And we have a panel who will look at some of the questions and scenarios that you submitted following last week's session. Thank you to everyone who sent in some questions and scenarios. We will respond to each one. In some cases, we received a number of similar scenarios that raised the same issues, and some of these have been combined, or we have chosen one that we felt covered the issues best. Some others may be more suitable to other events that we will be running in relation to specific clinical groups or particular issues around consent. But thanks again to everyone who sent them in. And as always, you can contact the office with any queries you have around cases arising. Today's event will be recorded and will be available on our website, hse.ie/National Consent Policy. In terms of CPD, we have 2 CPD points from the RCPI for today's event and 1.5 CEU points from the NMBI. And those are both available for people who have attended this event live. It's not possible to get those from watching back on the recording. So without further ado, I'll hand you over to Dr. Philip Crowley, National Director for Strategy and Research. Thank you, Philip.
Thank you, Elaine. Great. Amazing attendance. Fabulous to have so many colleagues coming together around this really important update of our national consent policy. There's been great interest in the policy in general, but also and obviously in the background to the Assisted Decision Making Act going into play last April. There's nearly 1,000 people on the webinar already, and it's still climbing, so that's really heartening. I'd really, I guess, like to acknowledge the work of the National Office for Human Rights and Equality Policy, an amazing team, very understaffed, may I say, maybe I would say that, but it's true, and do fantastic work around, particularly a major focus on the Assisted Decision Making Act and how that plays into other policies as we're exploring today. They really have gone out of their way, I think, to support staff and services around implementation. They provide leadership and guidance around how to comply with the ADM Act, and it's an act that has exercised people in a good way insofar as people understand how important it is to people's rights, as do we, and we really welcome the act. But they also understand, that it has certain implications for practice that we need to really get our head around, so as we operate carefully and within the legislation. And really enable people to exercise the rights that are articulated in that Act. The updated consent policy is a further example of bringing the ADM Act into life, really. Elaine Cueva and co-chairs Mary Donnelly, who will be speaking next, and Sean O'Keefe, have worked very assiduously and carefully to show how the spirit of the Act can apply in day-to-day practice across our health services. I'd like to really thank people who've worked with us on this, because you don't do these things on your own. The HSE Office for Legal Services has been really helpful, and the State Claims Agency for their contribution and support and guidance to make sure that that we get this thing right. So today's session is an opportunity, I think, for us all to explore the real kind of questions about consent and particular scenarios that arise in practice. And I work clinically in general practice in the homeless service, and there will be things for me to learn out of this as well, for sure. An important theme that is emerging is about how we as healthcare workers must support each person to make their own decisions, rather than focusing too much on the whole assessment of capacity issue. So look, I think it's going to be a really good webinar, and I think it's wonderful to see we've over 1,000 participants now, stopped counting, I think. And so I commend you to the webinar, and thank you for asking me to open it. And I'd like to hand over now to Mary Donnelly, who will bring us on through. So thank you all very much.
Thank you very much for that, Philip. And just to reiterate the point you made regarding the tremendous work done by the National Office for Human Rights and Equality Policy. And I suppose I should single out Elaine McCauley, who has been leading on this revision of the consent policy, but all of the team have done phenomenal work there. So it's my pleasure today to chair this session. And as Elaine said, we've had a good number of questions have come in following our discussion last week. And we're going to try to address as many of those as we can. We have an expert panel, and I suppose what really sets them apart is each of them have been are working at the coalface, and they come with that kind of practical and grounded experience, which is of course very much what you want to hear. So we have Professor Sean O'Keefe. Sean, I think, well, actually, none of our panel today are strangers to you, but certainly not Sean. Sean's a consultant geriatrician in Galway University Hospital. He co-chairs with me the National Consent Policy Advisory Group, and he's the clinical lead for assisted decision making. So always wonderful to have Sean's contribution. We're also joined by Caroline Howarth. Caroline is the Director of Adult Clinical Services in St. Michael's House and has been a big supporter, I know, of these webinars, and again, very much engaged with on-the-ground issues. And finally, we're joined by Joanne Condon. Joanne is the National Manager for the National Advocacy Service for People with Disabilities. And again, Joanne is seeing issues in practice on a day-to-day basis. So we're again absolutely delighted to have her with us. I just want to say a couple of very small things before we begin. And the first is we've had a number of sets of questions which show, I suppose, concerns which are out there in the system, but which are in some senses not addressed directly by these changes to the policy. And again, to remind you that all we did with the policy was to update it in light of the Assisted Decision-Making Capacity Act. So in particular, there were questions on the nursing home support scheme and local placement forums. And just to reassure you that these are being worked on separately, but we won't be dealing with them in any depth today, although we do have one question on CSAR, which we will be dealing with. And then the other issue, which I know is a huge issue, and we all know is a huge issue for people in practice, is that issue of deprivation of liberty. Sean will talk about aspects of it in his presentation. However, again, the Assisted Decision-Making Capacity Act doesn't provide any kind of encompassing solution, or indeed solution at all, in respect of deprivation of liberty. The Department of Health is in the process of developing legislation in this respect, but that is still a little bit off. Certainly we're looking at next year or probably the year after. So I'm very happy now to turn to Sean, who is going to take us through various aspects of the policy, but in particular the 3 appendices which set out templates which you can use. It's important to say before we do turn to Sean, however, these are not mandatory. You don't have to use them. You can take them if you find them useful and adapt them for your own services. You may have some things you want to emphasize in different ways. So these are not mandatory templates. They're simply templates which are aimed to make life, if possible, a little easier for you. So with having said that, I'm going to turn over now to Sean, who's going to take you through the templates. Over to you, Sean.
Thank you, and hello everyone. I'm going to take you once more through some of the templates and the appendices that we've developed in the HSE National Consent Policy, just to explain how Assisted Decision-Making Capacity Act will impact on it. A reminder again about the importance of the guiding principles when people lack capacity. These are musts, so there's not a choice on somebody who's an intervener in these circumstances. And we always have regard to the importance of these guiding principles when thinking about consent also, where people may have challenges in decision making. Now, most treatment decisions are not interventions under the ADM Act unless there is an existing support arrangement. But we've taken a position in the policy that healthcare professionals should act as if the decisions were indeed interventions and apply the guiding principles in those cases. So the first appendix is looking at an intervention, and the question to ask is there a decision support arrangement in place? Because if there is, then you respect it, you respect the scope of it. So you go through the different tiers of support that are possible, the decision-making assistance, co-decision making, where decisions be made jointly. There might be an advanced healthcare directive and a designated healthcare representative in some cases, and not many at the moment, so it'll be a while before these appear. There may be a decision making representation order or a representative, or there may be a relevant enduring power of attorney with an attorney. And if there is an arrangement and if the treatment falls within the scope, well, then you have the basis for consent, and that will be recorded. I'll show you later. If the answer is no, on the other hand, if there isn't a decision support arrangement and or it's not within scope, well, then you think about, is the intervention for the benefit of the person, and think about the various aspects of that, optimizing health and well-being, that it's consistent with their will and preferences, if ascertainable, consistent with their beliefs and values, and with the views of those consulted. And we go through those who must be consulted in a moment. Remember, for any decision, for any intervention, you need to be very clear about what the decision and what the proposed treatment or intervention is, and think, is it necessary at this time? Think about who was consulted and their views, that it's necessary and proportionate and the least intrusive option for the person. Record the efforts that have been made to help the person participate in the decision. What are the past and present will and preferences regarding it? And again, document that. Relevant beliefs and values, in particular if they're expressed in writing. And then are there other factors that the person would consider important and would want you to consider? Appendix 7 is a way of recording the basis of providing a treatment if somebody's capacity is in question or is lacking. And it may be that you confirm it'll proceed on the basis that it's consistent with will and preference, it's for the benefit, and it's consistent with those you've consulted. Sometimes there'll be cases where will and preferences can't be ascertained, and you think about the benefit of the person. There are certain people who must be consulted, and these are decision supporters, whatever the scope of the arrangement, and anybody, obviously, the person asks you to consult. But then there are others who may be consulted, and we take the view that really in cases where will and preference is not ascertainable, then they should be consulted. And these include people caring for the person, anybody who's a genuine interest in the welfare of the person, and healthcare workers are also important. I'm going to go through a number of cases, and it's a pity to start off with disappointing you all, but this case rings true. I'm a geriatrician. Dr. Siobhan Ivreen. Siobhan is an old age psychiatrist. We know these cases. We know the amount of angst they cause to healthcare professionals. And it is where there is considerable risk, where somebody is struggling at home. And what are you going to do when the person is clear to want to remain at home? And others, often family member, don't think so and want to progress a nursing home support scheme application. And these questions come through as to where do we go? And the disappointment is this is not dealt with in ADM. If deprivation of liberty is sought, then decision supporters have no powers of detention, no powers of coercion. Geriatricians, psychiatrists, local placement firms, none of us have powers of detention or coercion. There will in the future be new liberty safeguards legislation, but it's going to be a while. And for the moment, if we're talking about detention or deprivation of liberty, then it does require an application to the High Court under inherent jurisdiction. And that's totally separate to ADM. So ADM, unfortunately, didn't deal with it. It's going to have to be dealt with separately. If you think about it in general, inherent jurisdiction applications, there's a high bar for detention. The courts decide what reports they need, and almost invariably they're going to look for a medical report, but often others as well. And the whole issue about if consent for capacity assessment is refused, well, in the case of inherent jurisdiction applications, you will be dealing with the solicitors for the HSE or for an organisation, and they should be consulted with. I would just say one thing, and that is steady on, which is we really do not want to go around detaining people against their wishes. Have all alternatives really been exhausted? Is detention contrary to what they want really for the benefit of the person overall? What about persuasion, coaxing, involving others? And often many of these cases are resolved with time and with giving support and giving people space, because proposing that they leave home and move somewhere like a nursing home is a massive decision, and people do need time to come to terms with it. But I'm not going to continue dealing with that because it isn't the subject of this meeting. A similar case is a lady with multiple infections and cellulitis and necrotic tissue, and the vascular team think an above-knee amputation is recommended, that she's going to get serious sepsis and infection in the leg. And she consents to surgery and then revokes consent before surgery starts, and she has delirium. Again, these cases are not uncommon, and for all of these cases, they need to be considered on the individual facts. Here, the starting position would be that one would be respecting the withdrawal of consent. Treat delirium, and it may well be that with treatment, then she can make her own capacitous decision about whether or not to proceed. ADM again gives no powers of coercion. It doesn't interfere with you providing emergency treatment. The least you can get away with doing in the circumstances using the so-called doctrine of necessity. But amputation, contrary to the wishes of the person, is a massively important decision, and that would require again application to the High Court. And if cases are urgent, the High Court will see them urgently. But again, it's not an issue for ADM. And remember, your judgment about lack of capacity, even on a functional basis, doesn't give healthcare professionals new powers. Again, in these particularly difficult cases, it will be applications to the High Court. Here's another case we received from disability sector. John, mild intellectual disability, smokes and maybe getting COPD, and staff have tried to get him to cut down, but he's going to continue doing what he does, particularly when he goes out for some pints at the weekend. And the question was, do the courts have a role to play with what is labelled as perceived unwise decisions? And the answer here is very easy: no. First of all, his capacity isn't actually in question. The label of an intellectual disability doesn't call it into question. Even if it were in question, for argument's sake, his will and preference is clear. And maybe he's acting unwisely, but why would we hold poor John to different standards from the rest of the community, where plenty of people smoke and drink to excess? Would an intervention be proportionate? I really can't imagine anybody going to court to try and force them to give up the cigarettes. And again, ADM is not about forcing people to make good lifestyle choices. Another case, again, from the disability sector, and these cases have been increasingly common in recent months. And this is Joe. He's no family, and here he has a severe intellectual disability and is non-verbal. And he had bowel screening before, which went well, and there was an abnormality, and he's due to have a follow-up colonoscopy. And staff really have done all of the right things here. They've user-friendly information to try and get across things to Joe, and they've told the hospital staff how best to communicate with Joe. But the staff in endoscopy have requested a signed consent form from disability staff or from a next of kin, or threatened to discharge him from the service. And this kind of stuff really shouldn't happen. And here I go back to Appendix 7, the summary basis for treatment. And here, Joe went ahead with the bowel screening before, but there is no ascertainable will and preference, let's say in this case. Colonoscopy is clearly for his benefit. And then we go back to what we've said about consulting people, if appropriate and practicable. And here, Joe doesn't have a family, and it's the staff who care for him in the disability centre who know him best. And somebody who wants to provide the treatment should be checking with them that they think it's the right thing for him. And really, staff tick all boxes. They're engaged in caring for Joe. When you're with somebody for a long time, you genuinely care for their welfare, and they are healthcare workers. So really, the person providing the treatment should be talking to them. But if it's for the benefit of Joe, then clearly the treatment or the investigation should go ahead. And questions say, but who signs the consent form? Well, nobody, and nobody has the legal authority to give or refuse consent on behalf of Joe. And there is no support arrangement, and it doesn't seem necessary that there needs to be one in this case. The person providing the treatment or the intervention should record the basis for treatment, as I showed in the previous slide, and then just records their own information after it. And that's enough to allow the procedure to go ahead. You may say, will that work in all cases? Well, sometimes it won't, and it can't be exhaustive about circumstances where seeking legal advice and maybe considering looking for a decision-making representative or representation order would be necessary. But sometimes you exhaust the guiding principles and there is a problem. There may be a conflict between the past and present will and preference of the person. Maybe the person is making a choice that seems inconsistent with what you know of their beliefs and values. Maybe it's a disproportionate risk of harm in relation to the benefit of their choice. The intervention might be a major one and carry a risk of serious complications with lifelong adverse or limiting consequences. Or there may be disagreement between healthcare professionals and those consulted regarding, say, the person's will and preference, or indeed the benefit of an intervention for the person. Here's another case, and again, it's one that has cropped up before. Anita has moderately severe dementia and is cared for by a daughter, June. And she's always named June as the person to be consulted in the case of an emergency or anything else. And she's now had an upper GI bleed, which is probably due to aspirin. And the doctors want to do a gastroscopy. They want to look down at the stomach and the gullet. And June doesn't agree. She thinks it would be too hard on her mother. Anita herself isn't able to give a clear response because of her dementia. And staff asked, do we need to go to court for a DMR? Because there is disagreement here between healthcare professionals and the daughter. Again, my response is steady on. June can't give or refuse consent, but she is the person named by Anita in the past to be consulted, so her views must be taken into account. If you think about it, June knows her mother better than any healthcare staff and cares about her on a personal level. And we absolutely do want June on board with any decision, not because she can give or refuse consent, but simply because she's somebody very important who cares for her mother and where the mother wants her to be consulted. So yes, I've just said before of the significant disagreement between those consulted and healthcare workers regarding the benefit of an intervention, then one could consider going to court for a decision-making representative order. But really, would that be reasonable and proportionate here? Often when family members object to a treatment, the first thing is to step back and ask yourself, are they right? And maybe they have a point. And in this case, I have a strong suspicion from the vignette given that June may be right. An OGD isn't absolutely essential. One could treat it simply as a non-steroidal induced bleed and wait and watch. So I think we wouldn't be dashing off to court and picking a fight with June here. We'd be engaging with June and discussing the pros and cons and trying to get everybody in agreement rather than seeing court as some kind of first response. Here's a case of Sean. And Sean needs his regular follow-up cystoscopy for bladder cancer. And the case presented says it's urology known well over the years. And he has Alzheimer's disease with a MOCA of 15. It notes that he recently made an enduring power of attorney with his son. And Sean and his son are happy for the cystoscopy to go ahead. But the surgeons have sent a referral, in this case, to the geriatric medical team, saying query lacks capacity. Needs capacity assessment, and somewhat aggrieved question from the geriatric team saying, do we have to do it? A number of things I'd say about this. First of all, what has been presented to me in the vignette doesn't give me any reason to challenge the presumption of capacity. And saying that Sean has dementia or waving a MOCA or MSE score about doesn't challenge this, and nor is it relevant to a functional approach to capacity. Sean doesn't have to prove he has capacity is one point. The other is he's had cystoscopies before. He's used to, he knows about the procedure, and he should be supported to make his own decision. Urology know him, and they know their own procedure, and there may well be a good rapport between staff and Sean, and they were able to communicate with him before. And again, their thinking should be, we want to support Sean to make his own decision. What about the enduring power of attorney? Well, it looks like it was created, but not registered, and it only takes effect on registration. In any case, an EPA can't cover treatment decisions. So you may say, what's the point of a capacity assessment here? Certainly you would need it if you were going to register the EPA, but I don't think that's of any relevance in this situation. And why would you go to court in this case? This really should be soluble without thinking about court. One thing I would say is important is that Sean has gone to the bother of creating an EPA. He knows he has a condition that may deteriorate in the future, and he's engaged in forward planning for non-healthcare decisions. One should encourage him to think about an advanced healthcare directive, maybe with his son as a designated healthcare representative, and that would mean that healthcare decisions in the future would also be covered. When you're thinking about the sample recording of consent process, this is Appendix 8 in the consent policy. And in this case, you'd hope that consent would be provided by the person themselves, by Sean, even if you require some assistance to do so. And it's also emphasised again that the EPA doesn't cover medical treatment. Let's say, for argument's sake, that Sean wasn't able to make his own decisions, despite support. We'll then think back to Appendix 7 on the summary basis for treatment. And in this case, the procedure, the cystoscopy, will proceed on the basis that it's consistent with the person's will and preference, it's for their benefit, and the surgeon will have consulted those who must be consulted. In this case, his son, the person Sean, would want to be consulted. And in that case, one simply records that information and signs it, and one can proceed with treatment on that basis. So again, it's about not going to court unless we have to. We have mechanisms and tools that can be used to solve problems, but the spirit of ADM is about supporting people to make their own decisions. And we hope that the consent policy will enable you to do that with people. Thank you very much for your attention.
Many thanks for that, Sean. Again, very practical and grounded, which I think is very helpful. And I hope that the rest of our discussions will have a similar groundedness. And for this, we'll be calling, or I'll be calling on the panelists to respond to particular scenarios. And these are scenarios which people have sent in. So they're very much things that are troubling people out there in the system. So I'm going to begin with my first one, and I'm afraid, Sean, there is no rest for the wicked, because I'm going to turn to you straight off on this one. And this scenario is, can one proceed with an intervention? It's up there on your screen. Can one proceed with an intervention if the person's will and preference is known as wishing to proceed? So they're happy to proceed. However, it is known the person does not understand the risks associated with the intervention. So this is something I think we close off fairly well in the consent policies, Sean. So I might turn to you on that one, if that's okay.
Yeah, it's very much a bit like Sean in the vignette, isn't it, Mary? So
yeah, exactly.
Will and preference is to proceed, and we're very keen that we're able to proceed in those cases without having to go to court, which would be burdensome. It doesn't understand the risks. It depends on the individual circumstances and how great the risks are. There certainly may be procedures for the risks are so great in terms of a real threat to life or life changing that in the absence of somebody being able to understand the risks, that one does have to consider a DMR application, but it's not to do that in all circumstances when one can avoid it. So in most cases, a la Sean, or indeed a la the previous one with June and Anita, we can proceed. Thank you.
Thanks, John. And of course, in a situation like that, you'd also be talking with anyone that has to be consulted, or with family members to be sure about the person's will and preference. And again, of course, always, and the consent policy is really clear on this, supporting the person to understand the risks insofar as you possibly can. And that's both from the Act and from the amended consent policy. Super, Sean, thanks a million. Going to turn to the next one, which again is up there on your screen. So, hi folks, I would just like to address the fact that a lot of healthcare professionals are as yet not fully on board with the consent policy. There are still barriers to accessing procedures for individuals with intellectual disabilities, where consultants are seeking consent forms from next of kin and refusing to proceed with procedures, even though this is in direct contravention of the policy that now exists. So I guess what we're talking here about is a culture change that our correspondent here is saying really hasn't happened. Sean, I might go to you first on this, and then I'll turn to Joanne and to Caroline. And basically what we're interested in here is getting the view from the ground from all three of you.
I think this is very similar to the case where I said, you know, that it shouldn't have happened with the endoscopy example. So it is an educational matter. If you like, people are just coming to terms with a new piece of legislation, and there is a change in how procedures are. So that's why we're having this this webinar, and why we'll be doing more of them, and why we have been over the last few months engaging with individual practitioners and with, say, staff and disability sector to try and get over these barriers and to explain the new system. So this is a start, but it's only a start, and that's going to be an ongoing job for all of us. Thank you.
Thanks a million, Sean. Joanne, from an advocacy perspective, does this ring true to you?
Yes, Mary, this is a predicament that comes up quite a bit in contact to our service, and very often it's actually questions coming from people who support people with disabilities. Very often in services, they're facing very practical situations where they're trying to support the person to access a procedure or a service, and this is the barrier. They're being met with you know, requests for consent from next of kin and so on. So we often give very practical advice in this situation. As Sean said, you know, we are in the midst of a cultural shift, and some people still have to become familiar with the policy or indeed implement it. So the very practical advice that we often give is to arm yourself with a copy of the policy. Bring it with you, print it off, bring it with you. And it's all about, obviously, everybody wanting to meet the legal and constitutional rights of people. And I think it's about bringing people's attention to the rights that are stipulated within the policy, and maybe making them aware that the policy has been updated in line with the ADM legislation, and highlighting that, you know, it's very important that everybody would comply with that. And hopefully that will open up a conversation and give you something very robust to base your engagement on.
That's really helpful, Joanne, and I think a really practical suggestion there for anybody who's listening, or at any point who's running into these kinds of problems, and just arm yourself with information, and hopefully now that this policy has been updated. And I should say that all of the principles that we're talking about have been in the policy. They're not new principles, but we have now updated it to take account of the Act very specifically, and hopefully that will arm people who are running into difficulties of this kind. Caroline, your thoughts from your work with adults with intellectual disabilities, how are you seeing things in terms of this question and this culture shift, and whether or not it's happening?
Thanks, Mary. I guess it was just to highlight that while acknowledging the real challenges in the scenario there, we are seeing situations arising in practice where medical practitioners or other health and social care professionals really are understanding and accepting of the fact that consent can occur in many different forms. And as we know, as per the National Consent Policy, it is specifically stated that valid consent can be both verbal and non-verbal. And in my experience at the moment, where this is working best on the ground is where the person themselves and their support staff or their broader circle of support can facilitate the treating clinician in understanding how he or she typically gives or refuses consent. And it's working well when there's sufficient time to gather knowledge about how the person understands information and making decisions, and how they can then express their decisions. And taking time to do this wherever possible is important, so the professional can be confident as to the consent being provided. And another additional consideration for people might also then be, you know, how is this then recorded in the clinical file? As a traditional consent form may not be possible or appropriate for the person to complete. So consequently, it would be really important for the staff member to note comprehensively within the case notes how and when consent was discussed and obtained and who was present. Thanks, Mary.
Thank you very much, Caroline. So some really valuable and important points there, that issue of documenting what's happening. And whilst that's time consuming, it can be extremely, or will be extremely useful for you should an issue arise. And also that issue of time. And of course, time is something which is in short supply for all of us, but the importance of taking the time to work with people and including family members and supporters. We're going to go on to our next slide now, and I'm going to draw on Caroline's wisdom again initially, and then I'm going to ask Joanne. So our next slide relates to John. And you'll see it here. He's in his 30s. He has a severe intellectual disability and he doesn't talk. Previously, his brother was key in making decisions, but staff now want to figure out how to support him to make his own decisions. And that's very much in line with the spirit of the Assisted Decision Making Act. Can you give any advice about how to support someone like this who doesn't talk? And Caroline, I know that this is something which you have a lot of expertise, so I'll turn to you first, if I may.
Thanks, Mary. I mean, I guess, first of all, it's really great to see this question coming in and to see staff thinking and acting in this way. And I think chances are, by asking this question, they're already off to a great start. But to add a few suggestions, so make sure you're putting John at the centre of this conversation. So what's important to John? What's important for John? What would be a key decision or any area where John needs to provide consent that would make an important difference to him in his life? And maybe that's a good first choice or decision to begin with. And once a specific decision or area requiring consent is identified, give yourselves and John time to engage in the planning that's required. I'm kind of assuming by the nature of this question that this is not a specific issue right now that requires consent and it's not time sensitive. So in that case, taking time is likely possible, and that's key when supporting someone who communicates non-verbally. A couple of other things, if you haven't already, start reflecting on how John generally communicates on a day-to-day basis and try to be objective about that. Many of us often over or underestimate the communication abilities of a person with a severe disability. Consider how he best understands information, maybe through routines, through objects, through individual engagement, maybe through familiar photographs, and then consider how he generally expresses his wishes to you on a day-to-day basis. That might be through body movements, vocalizations, through his behavior, his mood. And finally, I'd suggest broadening all that out with your knowledge of John, his past preferences, things he's enjoyed, things he dislikes, and asking people who know him well for their input on this, as the contextual information will be key to supporting staff in interpreting John's will and preference with regard to making this new decision or providing consent in the current situation. And lastly of all, just as mentioned previously, don't forget to note both this process and the outcome of any consent procedures or decision making in John's file. Thanks, Mary.
Fantastic, Caroline. Thank you. That was really comprehensive and helpful. Joanne, in your advocacy work, do you encounter issues like this, and do you have any thoughts around how to proceed in a case like this?
Yes, so our advocacy service has a particular remit to provide advocacy to people who communicate differently. So this is a situation that we deal with on a daily basis. And I would point first and foremost to the guiding principles of the Assisted Decision Making Act. The key ones being things like presuming capacity and, of course, providing any support that you can to maximise John's ability to make his own decisions. This will be a big change. We learn, from the case example that his brother has typically made decisions. And I think communication is really important there with all of the people concerned. His brother presumably knows him very, very well and will hold very important information to enable the staff to provide the type of support that will work best for John in enabling him to make decisions. So that's important as well to consider. Obviously learning then more about how he best communicates. Is it through social stories, role plays, assistive technology? You might consider plain English or easy to read documentation, other visual aids, or indeed things like law of sign language or SLT support, which Caroline has touched on already. and ensuring adequate time and space away from anything or anyone who may influence John's decisions. He's obviously been very used to a situation where others made decisions for him, and in order to transition to him now developing his own decision-making ability to give consent and other decisions, it is important that he is given time and space to do that. Caroline's touched on this a little bit, but in terms of preempting upcoming consent decisions, that is something I would advise. So have a think, is there anything that's known about that's coming down the line that's going to involve a consent decision, such as an elective procedure that may be planned in the near future? Because then that really gives you something very concrete to work with John on. You can make a plan, just pick a role play as one approach that you could use in terms of experiential learning. Let's say he's going for a procedure. There could be a whole plan put together around helping John to understand the kinds of things that are going to happen, and helping him to plan around his own responses to that. And that will also give lots of insight and understanding in how he can best be supported. We call this approach witness observer, but it's effectively observing people's responses to situations. That's also really important. So noting John's body language, his facial expressions, his distress, his contentment, and his gestures. All of these are huge indicators for will and preference, and they're all very important to be very, very tuned into. And of course, to document them all as time goes on. And decision-making muscles need exercise. So the key thing, the last thing I would say is really help John to practice to develop his ability to make his own decisions. Thanks.
That was incredibly helpful as well, Joanne. Thank you both very much for that. I suppose the key message there really is about planning. And as you say, it's really positive that staff are working with John in advance so that John will be supported to consent and make his own decisions when the time comes. But that advanced preparation and advanced planning is I suppose, really positive to hear. And your practical suggestions there were really excellent. Thank you both. We've got a CSAR's NHSS issue here in this next problem. So this is someone who sits on the local placement panel forum, and they would like to know how the ADM Act affects our task in approving or not approving a person's application for long-term care under the Fair Deal scheme. And in particular, they're concerned with applicants who have a diagnosis of advanced dementia. We are challenged by the top section of the CSAR form, which says, I confirm that the assessment process and purpose has been explained to me and I consent that information can be shared, etc. We are currently approving such people in good faith and for the benefit of the person, based on their obvious need for 24-hour care and in the absence of any dissenting voices. But this person would appreciate some clarity regarding their legal position if the decision were to be legally challenged. And I know, Sean, you've got a lot of expertise in this space, so I'm going to turn to you for this one, please.
Well, the first thing to say is to reassure the people who sent the question, it's an excellent one, that what you're doing at the moment is absolutely the right thing to do, to proceed, because it's for the benefit, you're in good faith and whatever consultation. And the example you gave has nothing to do with deprivation, which, as he said, raises new issues. What's happened post-ADM is that the Nursing Home Support Scheme Act has been amended to take account of ADM. So it's actually the NHSS Act is amended, but it's also important to say that the CSAR form or its equivalent remains a legal obligation in terms of accessing the NHSS scheme. So in the circumstances you outlined there, you really need to proceed exactly as you have been doing, because there's no choice, and to do otherwise would be to the detriment of the person. We also accept that the CSAR, as currently written, as it was written quite some time ago, isn't terribly helpful. And we're currently reworking it in consultation with colleagues from the Nursing Home Support Office and placement forums, just to try and bring it up to speed. So the current form, not terribly helpful, but what you're doing is absolutely the correct thing to do. Thank you.
Thank you very much, Sean. Very helpful answer there. So we're going to turn to the next issue which we have, and this relates to consent for referral. So this concerns consent for discussion at MDT or clinical team meetings. In our area, we currently obtain verbal consent from the client for discussion at these meetings. Is this considered rolling consent, or if a person is discussed, for example, once a month for 6 months, does consent need to be sought prior to discussion each month? Does verbal consent withhold, or is written consent required? And their clinical coordinators trying to standardize consent, referrals and paperwork across clinical teams. And is consent at referral stage required? And I think, and I'm going to turn to you for this one, Sean, mainly, and I might chip in a little bit on it. It sounds to me like this is related to data protection as much as anything else, in the sense that the concern is sharing the person's, the patient's or client, as they're described, their information at clinical team meetings or on referral. So Sean, would you like to come in on this one, please?
Yeah, I'll start. I think I have a slide actually after this.
Elaine, you might hop onto the
Lovely.
slides there.
So there is a very helpful memo to staff, and that's the link. We can send it in the chat box as well. And it's not to get the two things entangled, our national consent policy in relation to treatment decisions. But the HSE has a legal basis for processing what's called special category data, including health data, where it's necessary for medicine, diagnosis, provision of healthcare, social care, all of the stuff we do. And we're not relying on the same consent as in the national consent policy. And all of this is entirely consistent with GDPR, and the quote is there. So you don't have to worry about that. You're doing the right thing. You're trying to provide high quality healthcare, and we are allowed to share data and use data for that reason. And that's part of GDPR law. Thanks, Mary.
Thanks, Sean. And I can't think of anything to add to that, because that's crystal clear and absolutely the case. The basis for sharing of information within the HSE is necessity. Essentially, the GDPR sets out a variety of reasons or bases on which consent can be, or excuse me, information about someone can be shared, their data can be shared. Whilst consent is undoubtedly important in many circumstances, for HSE work, it's based, as you can see there, on necessity for those purposes of medical or therapeutic reasons. Thank you very much for that, Sean, and we might move on to our next slide, please, Elaine. So in this case, we have a situation. In some cases, a person's will and preference is not necessarily in their best interest. What's the guidance in this case? And then what's, from a legal perspective, what is the legal view or understanding as to what is the benefit to the patient? Is benefit synonymous with the doctrine of necessity? So Sean, I might turn to you first to talk a little bit about that situation where someone feels there's a tension between will and preference and benefit, and then I might take up the legal aspect of things there. So over to you, Sean, if that's okay. And just to remind everyone that terminology of will and preference, and I should say best interests, is not part of the consent policy, and it's not part of the Assisted Decision Making Act. That term is no longer used. The term which is used instead is that term of benefit. So Sean, over to you first, please.
Well, there's a number of things mixed up in there, aren't there, Mary? And when we say for the benefit, we're talking about for the overall benefit. So it's very important for healthcare professionals that we don't reduce that to saying what's the medical recommendation, and that if you don't follow what the doctors and nurses and so on say, that then you're clearly doing something crazy or irrational or contrary to your interests. So people often are the best judge of their own benefit, taking into account their own beliefs and values. That's not to say that attention can't occur in circumstances, but we need to go back to the overall one. A person's will and preference, you give effect to it insofar as is practicable. So but it also doesn't mean we have to give the person everything they ask for. I'd like a villa in Kerry. I can't have a villa in Kerry. It's not on the table. So it is within the context of available options. So it's negotiating that tension where it exists in terms of will and preference with regard to available choices, and also also considering benefit in the broadest sense rather than in a narrow sense of being healthcare. Thanks. I think I'll leave it there. Thanks, Mary.
That's great, Sean. And just really to in a sense, confirm that when cases, and actually this was happening even before, even back in the best interest days, even before the Assisted Decision Making Capacity Act commenced, the courts very much look at what is in the benefit for someone's benefit, or back in the day, their best interest, from a perspective that what they think about it is important. So will and preference, the person's will and preference, what they want, their wishes and feelings, their values are at the heart of that idea of benefit. That isn't denying that other factors may also be relevant. So there is a difference between will and preference and benefit, but will and preference plays a very, very significant role in benefit. I should say, if you have a look at the consent policy, the consent policy is quite detailed, working through this idea of benefit, and it sets out the kinds of factors in addition to will and preference that are relevant. Like, for example, whether force would have to be used, or whether or how invasive an intervention might be. All of these are relevant from a what's for the person's benefit perspective. And we really did try to unpack that as best we could in the consent policy. So I do recommend you look at the consent policy in respect of that. Very briefly, to just address the second of those legal questions, is benefit synonymous with the doctrine of necessity? And the short answer to that is no, the two are different, although benefit is relevant in the operation of the doctrine of necessity. So again, if you look at the consent policy, you'll see a reference to the doctrine of necessity. And this is when an intervention, something is done to someone because it's without their consent, because it's necessary at that particular time. And I suppose the easiest way to explain necessity is it's often used in emergency or understood in emergency situations where you act for someone's benefit on the basis that you can't get their consent because you're dealing with an emergency situation. The National Consent Policy adopts the perspective, and again, you can read this in the policy, that sometimes the doctrine of necessity can apply outside of emergency situations. And basically what it says there is, if you have a situation, and this incidentally is what Sean has been talking about earlier, I'm simply giving you the legal bit of it here. So if you have somebody, an action is in accordance with their will and preference, it's made in good faith and for their benefit, and those you have consulted, as required under the Assisted Decision Making Act, all agree that it's a good idea. In that situation, the National Consent Policy adopts the position that treatment or an intervention can proceed without the need for court approval. And essentially the legal basis for that is the doctrine of necessity. I might move on from that, Elaine, if that's all right, please. Okay, so we've got quite a long one here, but I think it is worth spending some time reading through it. So if a person has no appointed next of kin officially, so we start with that, by courts or legally through a solicitor, etc., and no close family, and there is a query regarding the person's ability to comprehend information, or a lack of safety awareness and self-neglect. A neighbour brings the person to medical appointments. Where do we obtain or know we are obtaining informed consent? And what needs to be put in place or commenced for future planning? And then there's a more detailed scenario set out, which I'll just read through for you. So someone is 68 years old, lives alone, no family, in a porta cabin by choice. They're not linked to disability services, but would appear to have a mild learning disability. History of alcohol consumption, goes away for days at a time on binges, has a wound requiring frequent nursing care and diabetic and has poor self-management. Neighbour brings the client to medical appointments, brings them dinners, but if the neighbour isn't around, there's nobody. The neighbour is concerned regarding future planning. If self-neglect is apparent, at what point is it considered that the client doesn't or does have capacity for this self-neglect? What needs to be in place legally to show that the person's wishes are for self-neglect and that they have capacity to make that decision? If the client becomes unwell or professional concerns regarding safety awareness are raised, what needs to be in place and what needs to be sought? What area of policy or act can this be referred to? So a very detailed and I think very useful scenario set out there. Joanne, I might turn to you first, or I might turn to you for this one, if that's all right with you.
Yeah, there's plenty to be getting on with in that question.
There is indeed, yeah.
I think the first thing I would say is slow down, or as Sean puts it, steady on, because I'm possibly going to be a bit of a broken record here, but I would go back again to the ADM guiding principle. So the first starting point is with the person, and it's presuming capacity and providing that person with as much support as you possibly can to make their own decisions, and not assuming that the person lacks capacity simply because some of their choices in this example appear to be unwise. So the key focus needs to begin with the person and on listening to the person to try to understand what's going on for them, what's their will and preference, and any key considerations that might help us understand their perspective and situation. And then it's openly discussing the concerns and the risks with the person. So there's a couple of issues that are clear in the example given. There's medical needs, there's practical needs. And it's about exploring their openness and their views to accepting support. What struck me in the example is the person's clearly already accepting support from their neighbour in relation to lifts, in relation to accepting meals. They're also attending medical appointments. So there's already a lot of information there in relation to some leads on the person's own willingness to accept support and indeed to engage with medical professionals. So it could actually be very straightforward to connect with the person and put the right community-based supports that they require in place with their agreement, or explore alternative options as to how some of the risks that people have identified could be minimised. Remember, it's all about the least restrictive intervention that's person-centred and in line with the person's will and preference. And it's about considering, obviously, as we've said previously in other answers, how can you best support the type of communication that would work best? So easy to read, plain English, many others that I've already mentioned, and giving time. One thing I will say from an advocacy perspective, we see frequently adds more complication to these type of scenarios is intensity. Intensity by lots of different people who all are expressing concern and have an urgency about wanting to fix the problem, or such an urgency to manage risk that the person is ignored. So a very helpful tip is to try, insofar as possible, where it's not an emergency situation, to remove whatever intensity you can. Create time, create space, and most of all, begin with the person and hear what they have to say. If at the end of such engagements, the person still clearly does not understand the discussions, when all of those supports have been outlined and followed, then that's obviously important to seek further engagement on what can be done. If, however, they do clearly understand the risks and they choose that they do not wish to engage with the supports that are provided, or they don't wish to engage with medical professionals, and they're making an informed decision, their wishes must be respected in accordance with the National Consent Policy. I will throw a caveat in that because the matter of self-neglect has been mentioned, obviously, if you do have concerns that the person does not understand and you have significant concerns around self-neglect, then I would signpost you to your local HSE safeguarding and protection team, who are best placed to offer specific advice around that. Thanks, Mary.
Thank you, Joanne. That's really very helpful. And as you identify really well there, that this person is engaging, they're going to their medical appointments. So we're not looking at a situation here where the person is completely disengaged, and to build on that. Sean, I know you've, I'm sure, experienced many of these kinds of scenarios. Any
Plenty
thoughts?
of them. I exactly agree with everything Joanne has said, and safeguarding are invaluable as a resource in these cases. Just to remember that this man doesn't have to prove he has capacity. He can tell you all to get lost. That does happen. There are difficult cases, and there may be a lot of discussion around it. The other is a lot of people do lead what we regard as a poor lifestyle, and we just need to be very measured before using the self-neglect label. In some people, particularly, unfortunately, you will get binge drinking and things like that will occur. Again, ADM is not the act to solve this and to make people virtuous or to make them safe or to give healthcare workers any powers of coercion or detention. Thanks.
It's really helpful, Sean. Thank you. We might turn to the next one, please, Elaine, if that's okay. So this is a capacity assessment situation in relation to a transfer. So capacity assessment regarding making a decision for a resident if they are to transfer to another nursing home. Is a residence meeting more than enough? Supporting the residents in making a decision. Family are involved too to ensure they are aware of the situation. Family always say that the resident can't make a decision, that they have to approve prior to transfer, even though the resident agreed and understood during the meeting. What's your take on this? Some interesting points, I think, to be made there. Joanne, if you don't mind, I might turn to you again for this one.
Yeah, so the first question I'd ask on this particular example is why the immediate mention of a capacity assessment? Because it clearly says that the person agreed to the move and understood it during a meeting that was had with them. So yet the family are saying the resident can't make the decision and that they must approve the transfer. That's presumably where the issue is coming into play here. But again, the starting point is always with the person, presuming their capacity, seeing if they can be supported to make the decision. And it sounds like in this particular situation, there already has been a meeting with the person, there already has been engagement. So perhaps all that's missing here is just to make sure that the person has all of the necessary information, they've made a fully informed decision. If there's any doubt about that, it's simply about going back and revisiting that again. But if the service are satisfied that the person absolutely understood and make the decision, their choice needs to be respected. And it is about just ensuring that their decisions are free from duress. They're given, again, time and space, as I've mentioned before. And just a point maybe in terms of clarifying the role then of the family here. Obviously, there is no legal basis for the family to approve this decision, as they're suggesting that they must approve the transfer. That just simply isn't the case. But of course, as we've said already, the role that family play can be very important, and where they're involved, you may wish to consult with them. And indeed, Appendix 6 form mentions that idea of speaking to others. Now, I don't see any indicator here to do so unless the person specifically asked you to liaise with others. But if there's a concern or, as I said, some kind of a concern that the person hasn't fully understood their decision, if you are speaking to the family, I just want to make a very important point, and it's that you're asking to inform the decision, not to make the decision. It's a really, really important distinction to make that very often in our experience can get mixed up. When families are sometimes contacted to help understand a person's will and preference or their previous choices, they do sometimes misunderstand that they're being asked to make decisions, and that should not be the case. It's the will and preference of the person that's kept to the centre. Thanks, Mary.
Thanks, Joanne. That's really helpful and well worth reiterating, which is that yes, you're talking with families. It's really important to do so, but you're talking to understand the person, and the decision ultimately is that of the person and not of the family. They don't have the legal right to make that decision, any decision in that sense. We might turn to the next one, the next issue there, Elaine, please. Sean, I'm going to start this one with you because I'd again imagine it's one that you've seen in practice, but I will turn to the others as well. So in some senses, this is somebody with a cognitive impairment. They're living with their elderly wife. Their children are abroad. GP referral has been received because the client is not attending review by a geriatrician. Client is declining primary care input, but the wife is at this point extremely stressed. She's not coping as the client is awake and trying to leave the house in the middle of the night. Sean, I might turn to you first. Again, I imagine something you're pretty familiar with.
Yeah, they're always difficult. And the first thing to say is ADM doesn't solve these cases. They're going to have to be negotiated with people in the community along the grounds that we've been having to deal with difficult cases forever. That's simply the bread and butter for an awful lot of community staff. So you try and negotiate with the person, try and persuade them. Nobody can be dragged in against their wishes to a geriatrician review. There may sometimes be an opportunity for doing a home visit, for example, if that would be more acceptable to the person. But again, a lot of these, I detect an element that there's a wish for detention issues to come into play. That how can we force them to assess it or to be assessed? And ADM is not where this is going to be solved. So I'm afraid that it doesn't have an immediate solution beyond usual good practice, which is looking into negotiating. And most people eventually will accept seeing their GP, and the GP can review the medications, might be able to recommend investigations, might be able to recommend a medication change, but it's always going to be difficult, but not ADM in terms of solving it. Thank you.
Thanks, Sean. Thank you very much for that. Joanne, I might turn to you next. Again, from an advocacy perspective, do you see anything relevant here?
Yeah, one thing I think is worth highlighting, we see a little bit in the National Advocacy Service, is that the voice of the person here is really important to focus on, because sometimes the battle in these situations can become about trying to coerce and force the person to do what everyone else thinks is what needs to happen, without actually stopping and saying, has anyone stopped to ask the person why they don't want to engage with the geriatrician? Is there a reason that could actually be resolved? And we found that quite a number of times, is that in the kind of, you know, I suppose, efforts that everybody is focusing on to try and get it over the line, the appointment that everybody feels the person should go to, that can actually often be skipped. It seems obvious. And sometimes people identify really, really simple, practical things that can actually be addressed and remove the barrier for them going. So I know not every situation is that simple and it won't be resolved that easily, but I just wanted to highlight not to skip that step of seeing, is there a reason and can it be addressed? And maybe that will be enough to shift things.
Thanks, Joanne, and I think a very useful reminder there, particularly if in any kind of a fraught situation, that sometimes slowing down and looking for reasons is very useful. Caroline, this is a very difficult situation for this man, for his wife, and obviously for the staff who are trying to deal with it. Have you any thoughts around that aspect of things?
I think, Mary, the reality is that it can be very challenging as a staff member to assure yourself that you've done all you could and all you should when risk is being identified or perceived. And I think it's really important, where complex clinical decision making is concerned, that all staff look to the governance structures within their place of work. So essentially, nobody should be acting or making work-related clinical decisions alone. Instead, look for your support from your line management or your access to supervision, and be clear on how the clinical decisions, the information provided to the person, and interventions offered are documented in the case notes. And I would also say to document any refusal of interventions comprehensively as well. People will make decisions that others perceive as unwise. In the work setting, I think it's essential to manage any perceived risk around this through seeking support, escalating if appropriate, and documenting your actions. Thanks, Mary.
Thank you. And I think that's really important, that issue of documentation. I mean, we are emphasizing it. It's very much there in the policy, the value of documentation, of documenting actions. And that, incidentally, is why Appendices 6, 7, and 8, those templates are there. They're to try and make that documentation aspect as easy. And we know it's not easy, but as easy as possible. Thank you very much, Caroline, for that, and for recognising that genuine challenge for people. We've got the next one here, and we've got a special request here for Sean. from the person themselves. Could Sean please speak a little regarding the definition of capacity as opposed to one's insight? And that term insight tends to do the rounds quite often, particularly in medical speak, less so in legal speak. I've come across a case where a person had capacity to make a specific decision. They refused hospitalization and further treatment. However, this was overruled when a psychiatrist deemed the person, who has no history of mental illness, to lack capacity in understanding the consequences of refusal. Very interesting. The person was hospitalized and treated. This could put staff in precarious position regarding presuming capacity, and then on assessment deems that they have capacity to make perhaps a very unwise decision, but later overruled. Really interesting scenario there. So you have somebody who refused, and that decision was overruled subsequently on the basis of a lack of capacity. And quite naturally, the person is pointing out that this puts the first staff in rather an awkward position. Sean, you were especially requested for this one, so I'm going to turn to you because it's a toughie. Yeah.
Okay. Well, the first bit is the insight issue, and insight doesn't appear in the functional test of capacity in our legislation. So it is about understanding, using or weighing, retaining and communicating decisions. So insight we need to be very wary of, and we've mentioned it on previous webinars, and we can share the slides maybe later in the view box with you. But let's say it doesn't necessarily map on. In some cases it does. So if you say you've 2 legs and you only have 1 leg, then incontrovertibly you're lacking an understanding of core information there. But often it gets mixed up with your decision is unwise and I don't agree with it. So we need to unpack whenever we're prone to using the phrase capacity. Now, the circumstances here are very specific, and I'm not sure where the overruling is, but there's no question that sometimes people in good faith can reach different conclusions. Remember, we said that ADM doesn't give staff any new power, so that when there is a capacity assessment performed under ADM, it is with a view to going somewhere with it, because it doesn't empower you to do things, including hospitalize. And psychiatry and the Mental Health Act is a very different kettle of fish. So, but in good faith, people will reach different conclusions, and that's happened in a number of prominent court cases in recent months. So you do your best, you explain your reasoning, and sometimes the reason for disagreement is that people are seeing people at different times or in different circumstances, or maybe somebody seeing them when they're in better shape or in worse shape, or indeed that there isn't clarity about the information that people need to understand and to use their way. So wary about insight, but you do your assessments in good faith to the greatest of your skill. And remember that if there is any disagreement about whether or not the person lacks capacity, and then it will be sorted out either at a court level, or indeed it may be something that the DSS will be considering if there are different reports. But try and avoid the insight, I hope. Thank you.
Thank you very much for that, Sean. Very, very helpful. So that comes to the end of our slides, our scenarios. So I might ask the panelists, if they don't mind, please, to put their cameras on. We're going to do around the room in a moment just to ask for some final insights. But I just see a couple of questions, and I have to really commend the people who've been working behind the scenes. I see a lot of questions have been answered over the last 50 minutes or so. So very well done for that. I see one here, and I think perhaps Sean or Caoimhe, it's in relation to the CSAR. Can you clarify? I might go for you, Sean, on this one, because the world's leading expert on this. Can you clarify who, apart from the person themselves, can sign the form?
Right. The nursing home support scheme as amended is very specific about who can do these jobs. And as you say, it can be the person themselves, and we encourage them to do it, even if they require assistance to do so in some cases. But it can also be a number of other people, including decision supporters, if they're in place. And it can be, and this is where the new act was amended, so that now it can be only the spouse or partner or adult child. So it isn't anymore an adult relative of 18 or over under the amended Act. And they've also removed the provision for a legal representative to be able to sign for it. And then most importantly, if a lot of people but don't have a spouse or an adult child, that any doctor, nurse, or social worker can make the application on behalf of the person as a specified person. And there will be more available on that as we issue new guidance on the CSAR and how it interacts with ADM. Thanks, Mary.
Thanks a million, Sean, but that's really, really helpful to have for now. And I suppose people just to remember that the Nursing Home Support Scheme Act was amended and that those issues are dealt with. We're running out of time. I'm just going to do one quick question. I might leave this with you, Sean, I suppose, for the moment, if you don't mind, although if any of the others want to come in on it. And these are questions which were inspired by that sort of self-neglect kind of case, or that case which, that possible self-neglect, the person in the porta cabin. And the question there is, who starts the conversations there? So you've got and I suppose what we're talking about here is you've got a neighbour expressing concern about their neighbour and a possibility of self-neglect.
I still think it's to the safeguarding teams as per the HSE policy is the one. As to who does it, and it's really horses for courses. Sometimes it may be a general practitioner expressing concern, or it may be because it comes in from a neighbour, for example, who's concerned about something specific, or it may be the public health nurse has noted a change in somebody he or she is visiting. So it's very dependent, but the best route is through the safeguarding teams. And I thought there was a question in relation to it, but it is part of their duty to, they don't always be able to solve these, and some of them aren't soluble, but they would be the ones to go to when you're really feeling troubled about a case. Thank you.
That's great. Thanks a million, Sean. So I'm going to give you a chance to catch your breath, Sean, and I'm going to go around the room, but I'm going to put you last, if that's okay. Joanne, I might turn to you, and then Caroline, and then Sean. Just before we leave, a 1 minute or so kind of synopsis of the message you'd really like people to take out of this webinar and out of these changes to the national consent policy to comply with ADM. Joanne, over to you, please.
Thanks, Mary. Probably going to repeat myself yet again. I think what's really important when you're dealing with the area of consent is to slow down, start with the person every single time. And remember, consent is a process of communication, so you can't skip that. It's absolutely fundamental to what we're trying to do here. And the ADM guiding principles are your friend. I actually personally have them pinned up on my notice board. I think they're a fantastic resource in any situation where you're trying to figure out what's the best way to start this. They are your friend. So thank you, Mary. That's it.
That's lovely, Joanne, and well worth repeating yourself for. And hopefully the consent policy is also your friend, and we'll have people pinning it up all over the place. Caroline, if I could turn to you, please.
You've robbed my line, Mary. That's exactly what I was going to say. The consent policy, I think, is also people's friend, and if you haven't had the opportunity yet to look through it, or you were looking for this webinar as a bit of a catch up, I really would encourage staff to try and find some time to go through it. I know time on the ground can be really tight, but this particular policy has a lot of practical information and references to resources that I think people may find quite useful in supporting them in their day-to-day work. And I think when people go through the policy, they'll see information that they can use to navigate their practice. And I would also say perhaps to encourage discussion within their workplace, and anonymized where necessary, of course. But, I think to share the learning with colleagues is really important as well. So I would actively encourage that kind of discussion so that we can all learn from each other and understand where to go next.
That's brilliant, Caroline. Thank you very much. And I'm very sorry for stealing your line.
Great,
Sean, I'll say nothing for fear I steal your line as well.
No, I think we all have the same message, don't we? I said it a number of times during the talk, steady on. And I would encourage people to steady on. This is ADM is about supporting people. It's about not going to court. The consent policy is useful information, but all of the webinars, we've covered a lot of this territory a number of times from different directions. And it is to go to it because they're all recorded, they're all available. We dealt with an awful lot of questions that recur. I know there's a lot to come to terms with in the new policy, but I think also particularly to look, considering what we were talking about today, at the new templates and see whether they could be useful in terms of using them and adapting them in your own service to try and get over some of the difficulties we've heard about. Thank you.
Thanks very much, Sean. So it falls to me now simply to thank our three wonderful panelists. You were all really excellent. It was really a fantastic discussion, and I think grounded in your own experiences, which I think is always much more helpful. So thank you very much indeed. And for me to turn back to Elaine, who is going to close us out. Elaine, if I may.
Thank you so much, Mary, for so expertly shepherding us through a very busy panel discussion with a lot going on. And thanks to my own team in the background, Quiva, Jacqueline, Sandra and Shem, all responding to questions also. So those are our two events now. They'll be recorded, and that is the updated policy launched and those events available to look back on. But obviously we will be doing other consent events during the year, looking at particular clinical groups and particular other issues around consent, not solely confined to ADM issues. So please make sure you check out our website, hse.ie/national consent policy, join our mailing list. The easy to read document of the policy is now being updated to accommodate this update. We will also shortly be releasing 3 short guides on the updated policy, a guide for people using services, a guide for staff, and a specific guide for children and young people. Some of the questions that came in following last week related to DNAR. Part 3 of the 2022 policy is about do not attempt resuscitation. That section is unchanged in the updated policy. The reason for this is we have been carrying out a very valuable and thorough piece of research on DNA CPR decision making throughout 2023, and we're just coming to the end of that. And this year we will be working on a standalone DNA CPR policy. So for those people who sent in questions in relation to that, again, keep an eye on our website. It's a big piece of work we're in the midst of, and we look forward to updating you on that later on. So thanks again for joining us. Enjoy the rest of your day. Bye.